Good morning, everybody. Dumelang, Sawubona, Habari, Moribuanj, Molweni. I'm not sure, I'm forgetting some languages. You can teach me during the breaks. It's great to be here today, and the topic is really big, so I'm going to just do a bit of an overview and give you some food for thought as you listen to the other presentations. We only have 15 minutes, so it is a lot to cover, but there'll be kind of 6 broad parts to this. The information that I wanted to share. First, just to think about pregnancy and motherhood and HIV in adolescence, how they happen, do they happen together, does one come first, what do we know about this? And then what happens when the two of them actually overlap? So what does it mean to be a pregnant or a young mother or a parent? We can extend it to our partners, and the syndemic of it. But also then reflect on generational shifts. Some of us here, maybe I say I got a haircut recently as my midlife crisis, so I will stop pretending I am a 17-year-old with 25 years of experience. Have worked on this topic for a long time, and we'll often ask ourselves, why are things still the same? Except that the young people and the adolescents, many of you in the room have just maybe gone over 18 or still feel very young at heart. They're not the same generation that when I started HIV prevention and support work in 2005. So just what does it mean, these generational shifts, and how do we understand them, and how do we together work across generations to respond to these unique needs? And then I wanted to think a bit about living in adversity, and how do we understand these different types of crisis together, and where resilience can emerge. And then not forgetting that pregnancy and antenatal care and postnatal care and motherhood doesn't happen alone. It takes 2 people, minimum, to make a baby. Minimum. And it doesn't always happen in the happiest of circumstances, and I'm aware of that, and we'll talk a bit about that. But I wanted to just flag some data on adolescent boys and young men, not as the people who get women pregnant only, but actually as the young boys born in these pregnancies and families. And then to wrap up with some programming and resources, but being aware that many of your posters and presentations for the rest of the conference will add to this list that I'll get us started with. I had no conflict of interest other than I'm very passionate about most of the things in these slides and a lot of others. So one of the things that we've come to, a big body of research, but also lived experiences from you in the room and the young people that we support highlight that HIV and motherhood really have shared risks and vulnerabilities. They have similar pathways to health and life outcomes, but a lot of these are hidden. I mean, icebergs are not very common, other than if you travel south, from South Africa, but we know that there's a lot more than we see. And this is true for both risk of HIV, but also what results in early pregnancy and motherhood. And there is data, and this is analysis from Professor Ali Groves and Luam Gebekristos at Drexel University in the US, which looked at HIV prevalence by age, and the references are at the bottom. If you can't see them, I'm happy to share them at any point during the workshop. And we can see that there is a higher likelihood of living with HIV if you have been pregnant or have become a mother. This is in part a reflection of those shared risk pathways, but potentially also the additional exposures that happen when you have become pregnant or are a mother. And really, there's 3 circles of vulnerabilities or adversity that emerge. One is that it is hard to be an adolescent and young person. We all think we know what it is like, but being in the body with the hormonal changes and everything between 10 and 24 is really difficult. There's also added complications to being pregnant and early motherhood. In many ways, it's like doing shift work, and in many countries that is recognized, as something that should be coming with a bit of a warning sign, and yet we don't really give young mothers enough support and credit for it. Then HIV comes with its own complex sets of biological, biosocial, and psychosocial complications, and there are young people, and particularly young mothers, that are at the center of all of those 3. And the numbers are really important, and thank you for all the really important figures during our TED Talk earlier, so I won't repeat them. But when it comes to pregnancy and motherhood specifically, if all of us here were, statistical averages, 1/3 of us would have been born to a mother before the age of 20. Now, I know we're not all from the continent, but just to say that, it's we're everywhere, the children of young mothers. So it doesn't mean that if you're born to a mother under 20, your life is going to be horrible and difficult, but there is a large cohort of children who start their life in difficult situations. About 45%, so just under half of pregnancies happen amongst 15 to 19-year-olds, and the majority of them are unintended, and they happen before the age of 17. Mortality remains one of the top 5 causes of death in 10 to 19-year-old girls globally, and that is linked to complications due to childbirth and HIV, even though it's hard to disentangle the sequence of these because maternal mortality specifically is measured immediately after childbirth, but some of the complications take a long time to emerge. Unfortunately, or in some cases this may be desired, but in most cases our young mothers tell us they weren't ready. More than half have another pregnancy within 2 years, which is considered rapid repeated pregnancies and comes with its own additional challenges biologically for the young moms. And we've heard about the numbers of young women living with HIV, but it is over 20 million adolescent mothers in the continent at any given time. We looked at what this means in terms of the experiences of HIV-related risks. So condomless sex, sex with a partner that is 5 or so years older. And this is not to say that being a mother makes you be more risky or risk-taking, but once you have sex early and once you become a mother or are married, a lot of these, what we would consider exposures to HIV, are just much more likely in your life. So at the bottom in the circles in light blue are the likelihood of reporting the outcome. I won't read all of them. If you have not yet become a mother and are not married, which is, one of the 4 possible combinations. You could be neither married or a mother, you could be just a mother, you could be married only as an adolescent, or you could be both. So what we looked at here, and this is data from nearly 29,000 adolescent girls and young women from the Violence Against Children surveys, analysis led by Dr. Jay Barua at UCT, and we looked at what were the likelihood of reporting these HIV-related exposures. And what we see is that if you are a mother, you are much more likely in the dark blue circles to report higher exposures to these HIV risks. But if you're a mother and married, your risks are even higher. And we did hear about how there's restrictions and also self-efficacy challenges with being married and a young mother, including legal consent barriers. But the impetus, the imperative to respond to the needs of adolescent girls and young women who are married and mothers is really important. And how do we do that in different contexts? In South Africa, marriage is really not very common. Certainly not the official one, but even customary marriage. In Lesotho, just next door to us, it actually often precedes early motherhood. So the service provision and our response has to acknowledge these differences. There is some good data, and you'll hear really amazing findings on PrEP, and I'm not a biomedical expert, so I will not try to cover it. But in the Eastern Cape of South Africa, where some of our colleagues in the room work in, which is the graph on the left, there are some good news. Our PrEP rollout, which many of you have advocated for and have worked to promote, is getting to this high risk or high vulnerable and high need group of adolescent mothers. This is data from our Hey Baby study, and you can see when we started the work in dark blue, just under half had ever heard of PrEP. And as we followed up on them, and this data is actually still being cleaned, so this is very preliminary, we've gone up to over 80% have heard of PrEP. And from the Western Cape, where colleagues at Desmond Tutu Health Foundation will share even more magical information, we've seen, and this is analysis from Dr.to-be Jenny Chen Charles and Professor Linda Gale-Becker's team and lots of other colleagues from the Fast PrEP collaboration here. We see that pregnant and breastfeeding mothers were much less likely to continue PrEP, but younger women amongst those mothers were even at greater risk of discontinuing. But the good news is that when they accessed PrEP at mobile clinics that the Fast PrEP team provides, and they're really wonderful models, they're more likely to continue. But why is this? We really see that there's this, we called it the network of social norms, and Luciana will share some findings on how we can address these complicated networks, but there are these foundational norms that are linked to adultism, that health workers know it better, or adults know it better, seeking permission, foundational norms around gender. Boys and men can really be violent. It's allowed to their partners if they're unfaithful. And around privacy, that you should really be taking PrEP in secret to avoid stigma, but also your partner not knowing. And this really results in some of these discontinuations that we see, not just in PrEP, but also contraception. But there's also a lot of other factors that are in these two other boxes, both at the individual level, but also environmentally. Now, I'm going to run out of time, so I'm going to go a bit faster in these other ones. But the needs of adolescent mothers living with HIV are quite unique. They are similar to adolescents living with HIV. They're similar to adolescent mothers who are at risk of HIV. But there are some additional needs around safe conception. And this is data from South Africa and Lesotho, where you can see in the red lines, it's the mothers. In the blue lines, it's newly... Well, I hope I didn't press anything dangerous. It's those who have not yet had children. The good news is that adolescent mothers are much more likely to use hormonal contraception, but the rates are still quite low. And they're low whether you're living with HIV or not, which means that the only ability to plan future pregnancies is coming through condoms. And we know how rates of condom use are in our populations, and it's hard to do. But then I'm a social scientist. I don't only think about PrEP and condoms all the time. We also think about other aspects. And as Aaron said earlier, the young woman shouldn't be defined by HIV status. And often in conversations, we say to each other, a young woman doesn't wake up in the morning thinking about her pills. She wakes up thinking, am I safe? Do I have enough food to eat? Am I happy? Is my boyfriend going to talk to me today? Or my partner? Is my caregiver available to look after my child so I can go to school? And what we see in our research is that adolescent mothers living with HIV are really living in this syndemic. They're twice more likely to not be enrolled in school. So we really need to think about supporting young mothers return to school, but what are we doing differently for adolescent mothers living with HIV? A similar syndemic also emerged in our data when it comes to adolescent mothers living with HIV, including increasing rates of suicidality. This is not an easy topic, and the fact that I won't speak about it for a long time doesn't make it any less important. But our colleague Tetelo Makamedi has just been looking at suicidality data over time in this cohort of adolescent mothers living with HIV and not living with HIV. And unfortunately, we see really increasing rates of suicidality amongst the moms living with HIV. We do not know yet why, though there is indications that it is linked to food insecurity and potentially exposure to violence. Perhaps not many of us are surprised by that from our qualitative data, but it is very strong in the quantitative data as well. And one of the most important things about this endemic of adolescent mothers living with HIV, it's also that there is also children involved. And these children also need not only care and love and nutrition in their early life, but they also need access to HIV prevention. Research from Dr. Camille Vitesale, who worked on the Hey Baby data, and I can share a bit more on her work, has found that only under half of the children of adolescent mothers in our work, whether they're living with HIV or not, had full immunization coverage at 1 year. That's quite low. This is in the Eastern Cape of South Africa, where obviously some challenges remain with our health system, but this also means that they probably have similar gaps to accessing PMTCT and post-birth access to prophylaxis and prevention. All right, let's do a bit of an engagement. How many of you here were born before 1945? Oh, okay, there's no builders over here. How many were born before 1964? Any baby boomers in the room? No. Okay, how many were born? Wonderful, great. And thank you for disclosing that. Okay, how many were born? Feel free to not do this, but if you want to, please do a wiggle. How many were born before 1979? Okay, I'm next. Great. Please scroll your eye over your favorite, your iconic toy, which is, rollerblades, frisbee, Rubik's Cube. How many are Generation Ys, 1980 to 1994? All right, quite a lot in this room. Guys, we have a big job to do. We are doing all this work, all of us who put our hands up until now, for the next 2 slots. Okay? Which is Generation Zers, 95 to 2009. Show up, everybody. Brilliant. I hope you're enjoying your folding scooter. And any Generation Alphas? It would be surprising if you were, because you would have to be about just under 15. But how many of us here have children who are Generation Alphas? Okay? Some of us may have children of the prior generations, by the way. I won't make you raise your hand a lot. But almost everyone in this room isn't in the generations that are adolescents right now and are going to be adolescents in the next few years. So, colleagues, we have a lot of work to do because we have to shift our minds. This generation is a generation of growing inequalities. The 2/3 will live in countries where inequality has increased or is increasing. 25% are going to live in places where the ratio in income of the richest and the less rich people is increasing. And there's been a growing reports around this idea of the inevitability of violence. I'd like to think that that brings up the inevitability of resilience, but that is where our work has to be. There are lots of types of risks and that are different by generation that we have to respond to. So I did a little bit of a check. This is a crash course on Gen Z and Gen Alpha. Now, some of this does not yet have data from maybe our region because we are redefining what it means to be Gen Z and Alpha in this space. But you can see that there are some basic differences. There's also some great shared similarities. You know, they're all activist generations. This is also true of Generation Y, I'd like to think, and many of the people in this room. But Generation Alphas, they are not just digital natives. They have a digital way of life. And these are all extremely different ways of thinking. So it's up to us to think about how do we respond to these differences. And we need to respond to these differences in the context not just of COVID-19, climate shocks, and conflict, but also funding cuts, which many of us are describing with the same language as a pandemic, the same language as an outbreak, the same language as floods. And these are just some numbers from COVID-19. I won't read them. But if you scroll your eye through the impacts, they're shared risk pathways. And already we've discussed about how big the impact is. But our response has to be similar. I want to bring in the issue of climate, because if we're thinking about navigating HIV and sexual and reproductive health for the future generations, which is this talk, and I'm going to wrap up soon, we really need to think about how weather is shaping everything that we do, how it's shaping access to food, how it's shaping access to services, how it's shaping families and our response to crisis and those risk pathways in the iceberg at the beginning that we saw. And how are we responding and adapting to them in a way that is HIV sensitive or HIV seroneutral. We had data from our adolescents and young people in our teen advisory group who became parents during COVID-19, and it was an extremely difficult time. There will be another cohort of adolescents and young parents that will come by when? January 20 plus 9 months? Can someone do the maths for me? Oh, the first babies will probably be born very soon, unfortunately. So how are we going to be dealing with interruptions to services and the additional wave of unplanned pregnancies, or I hope not, but new cases of HIV, or even additional illnesses that are going to emerge from our service interruptions? And how do we learn from COVID-19 and other crises and what we did in that sense? I don't want us to forget about adolescent boys and young men. So I just want to give you some quick data on analysis that we did. Luciana will talk a bit more about this, and I'm just going to focus on norms and attitudes. And we looked at the violence against children surveys. They're a really rich set of surveys and information. And this is data from 5,000 adolescent boys and young men. What you can see is that the rates are quite high amongst both adolescent girls and young women in orange, but also adolescent boys and young men. In fact, in many cases, they're slightly higher amongst the young boys and young men. And what is particularly interesting, you do not have to memorize these slides, and they will be available at the end, is that the proportions of reporting these norms are similar from 13-year-old to 24-year-old. Can you see these graphs? They're very flat. You do not need to see anything else about them. It means that a 13-year-old has the same likelihood of reporting inequitable gender norms as a 24-year-old, more or less across countries. So these norms and these attitudes are formed early. It's our responsibility as parents, as programmers, to think about these young men not only as the young men who don't use condoms, If they had negative norms, their attitudes, they're much more likely to report inconsistent condom use, multiple sexual partners, sexual violence victimization of their partners, but also as themselves young men that may also experience violence themselves. And finally, there is a whole host of amazing programs that we know and we can do about. It's important to think about what are we doing to meet the most important needs of our adolescents and young parents. Access to food, it was associated with reduced HIV-related risks in our study in South Africa, and there's a really useful document that our colleagues have put together with the World Food Programme. Childcare is a critical component of most programs. Those of us who organize programs for adolescents and young parents, we often just do it on the side, but it's actually an intervention component because we know that without doing it, they will not show up. So how are we integrating it into our policies and our approaches? How are we making our adolescent services responsible? Maybe it is mobile clinics like the Fast Prep team and many of you are doing. Maybe it is about peer provider models, which we'll hear about later. Maybe it is about shifting things entirely online. But how are we making sure that we're not missing anyone through, with adolescent responsive services? And finally, it's important that we combine these into packages. Many of you are doing really important work, but it is to recognize the entirety of our adolescents and young parents. I'm not saying just mothers right now, and young people before they become parents, as human beings with all of their needs. We need to think about meeting all of their needs, not just their HIV-specific ones. There's the amazing model of the Jandiri young mentor moms and the cats, and many of you are doing similar models. You can see that data from their vertical transmission rates are down to 1% compared to the national rates of 1%. So there's really promising, amazing models that are available, which I hope to hear more about in the next few days. And there's a growing list. I'm trying to keep this table updated of really great programs, and I hope to have twice as many by the end of the conference. So to finish, and I know I've gone a bit over time, this is just a lot of food for thought for us to think. What does HIV prevention look like in the sense of integration of services? We've thought a lot about integrating services into HIV for the longest time. We had resources, we had funding, we had amazing cadres, passionate advocates. But as funding changes, this funding structure changes, how are we bringing that knowledge and those lessons and that amazing passion into integrating into antenatal care and maternal, neonatal, child and health care? How do we support HIV prevention amongst married adolescents? That is not as easy. There's the mother-in-law, not just the husband, right? There's the entire community. So how are we doing this in a way that recognizes their lived experiences? How are we safeguarding families? You know, when we talk about contraception and condom use, there is a fear that everyone will become, I don't want to name a country, but let's say some of the Asian countries where there's not enough children being born. We're not saying that people should not be pregnant. Our goal is to support the adolescents and young people to have children when it's safe and when they're ready. So how are we doing this with safe conception, respectful and responsive care, but also community and family-based support that includes male partners and other gatekeepers? And finally, how are we doing this in the context of syndemic? You know, when multiple bad things happen together in an HIV seroneutral status way. And just finally, because we've talked about a lot of difficult things, there's so much love in these young parents, everyone. These are just 2 quotes from a father and a mother, just to say how much they enjoy being a parent. And just to remember that everyone is just doing their best and trying to show up, even when difficult things happen to them. Thank you to all of our funders, and Kia leboha.